PopHealth Podcast is a public service of 24-hour home care.
The neat part was that had they not accessed services, we wouldn't have gotten a social worker in there who was able to get them connected immediately with a food bank to have food delivered into their home so that they didn't have to go out. But the really cool part of the story was the nurse case manager actually went home and actually made a dinner for that family, actually brought it back to them so that they'd have a hot meal. So when you think about, what we do and the impact that we have, right? This wasn't a COVID patient, but somebody who had been impacted by the COVID environment. Had they not accessed these services, God only knows, what would have happened to that patient and that family. And, and the nurses really didn't even talk about this.
Hello, everyone, and welcome to another episode of PopHealth Podcast. This is Gavin Ward, co-host of PopHealth Podcast. In today's episode, I had the pleasure of having co-host Zach Morgan sit down with me as we got to know a little bit better the CEO of Mission Healthcare, Paul VerHoeve. Now, we started to record these episodes and are putting them on YouTube, so you may notice we're not quite there with some of the syncing. But for the most part, this is an improvement from our first episode. So we hope you enjoy growing with us as we put our shows on YouTube during the pandemic. In today's episode, Paul talks about, one, his favorite burrito in San Diego. He actually grew up on the East Coast and actually spent some time in Italy in his early part of life. So he really didn't know what a good burrito was like. But that's not the focus of the show. The focus of the show is how he brought his wealth of knowledge from working with powerhouses like Gentiva and Vitas Hospice, and how he's able to impact Mission Healthcare, a regional strong player in home health and hospice based in California. He also talks a little bit about the COVID-19 outbreak and how his team is able to deal with the pandemic, and a very touching story about one of his nurses. We hope you enjoyed today's episode, and if you like today's episode, of course, you can learn more about the show at pophealthpodcast.com and find us on iTunes, Spotify, Stitcher, and of course now YouTube as well. Thanks, everyone. Enjoy the show. So, Paul, can you tell us something about you that might surprise the audience, something outside of the workplace, perhaps?
Yeah, as growing up as a kid, I actually had a father who had lost his father and his brother very early on in his life, and decided he wanted to be a physician, but actually didn't have the grades to be able to go to medical school. So he decided to go to medical school in Italy, which meant bringing a wife and two young children along with him. So we actually lived in Sicily and in Rome for a number of years while he was, one, learning the language, and then two, going through medical school out there. So pretty incredible experience. In fact, I was so young that when I came back, I actually had to be held back from starting kindergarten because I didn't know how to speak English. Obviously when you're out there, you try to immerse yourself in the culture and learning the language, and you come back to the States and there was just never English used in the home. And, they say kids pick up languages really quickly, but they also forget languages really quickly as well.
Wow. So do you still speak Italian today?
Unfortunately, when you live in Southern California and you have, Spanish that gets mixed into it, it kind of gets, just kind of changes everything, and you very quickly have nobody to speak to, and you very quickly forget, kind of how to speak. So I have parents that still do, but unfortunately, none of it resonated with me.
Wow. So how was there a culture shock when you came back as a young child, or?
Yeah, my memories as most kids, you wouldn't know, as all of us do, right? Whether you're in a good situation or bad situation, usually you don't figure that out until you're much, much older and can actually relate it to something. And, as a kid, as long as there's a place to play and people to play with, usually you have a pretty good memory of it. So, all of my memories were, as a very, very young boy. So they were positive, and, I remember good people and even better food. So it's all positive from my perspective.
All right. Awesome. So maybe talk a little bit about where you grew up. You mentioned Southern California, where you went to school, and ultimately how you ended up in healthcare.
Yeah, so I actually grew up in North Jersey, just a little bit outside of Manhattan. That's where I was born, and for the most part where I was raised. And then in junior high, after my father became a physician, he got his first post in San Diego. So pretty easy move from the hot, humid summers, the cold winters of New Jersey to, Southern California, where, as a kid, you just thought that, everyone lived on the beach and palm trees everywhere, and the ocean was smacking up against everyone's homes. But it was pretty easy to come out here, in the 7th grade, and just fell in love with the Southern California culture. Really from a healthcare standpoint, it's all I've ever done. I was a pre-med major, obviously coming from a physician family. My mother was a nurse. It was kind of, you were almost guided towards it.
Yeah.
But decided to kind of pivot and really fell in love with really the administration part. Right out of school, actually, while I was going to school, kind of got into home health, and I've kind of been in home health and hospice for, my entire career, which has been just a great choice and a great business to be able to lead and support individuals who do that type of work.
Great. I also have lived in San Diego. I've lived in San Diego for a while myself. Do you have like a favorite restaurant or spot down there that you go since you still live in San Diego?
Well, it's interesting that you bring that up. When you come to San Diego, they are known for their Mexican food. And once you get outside of San Diego County, we say the Mexican food changes. And, we don't even call it Mexican food. It's called taco shops. And, usually the less fancy they are, the more in a strip mall they are. Those are the ones that, you just remember. And I'll still to this day never forget the first time I had, what a real burrito was. Coming from the East Coast, you thought Taco Bell was about as good as it got. And then you realize what, Southern California Mexican food really was. And, obviously I haven't shied away from the plate since I got here.
I'm with you. The more the sketchier looking the place, the better the food. I know when I was working down there a lot, Gavin actually used to enjoy coming down to visit because we would go on tours of California burritos for work. So you had mentioned, although we could talk about San Diego Mexican food the whole time, we won't. But you had mentioned that you have always gravitated towards healthcare, but that you actually ended up in post-acute and have kind of stayed there and obviously been incredibly successful in that arena. You've worked for some of the largest healthcare players over the years, Accent Care, Vitas, Kindred, and now you're with Mission, which is very strong regionally, but not necessarily the national presence, or maybe at the time, not the national presence that the others did. What really drew you towards Mission?
First, having the opportunity to have worked for, big national companies, you really learn from people who have learned how to support clinicians who are doing this type of work. Processes are very good. The ability to manage, the key metrics are, in place. So that education was, by far the best that I ever could have asked for. But I think as, my career continued to evolve, you take on more and more responsibility. And, really what I fell in love with was, the ability to not be too far away from the field level clinician, to not be too far away from, the local strategies, to be able to hear the success stories of staff, to hear the success stories of patients, was really important to me. So, when I had the opportunity to join Mission, it was a company that was, very culture focused, took care of its people. I felt like it aligned, very well with kind of what my style was. And, having been here now a little bit over a year, was just a great decision from my perspective, because I was able to really join an organization that, I believe, focuses on the right things, which is, employees and patients.
Yeah. And what are the current service lines that Mission offers?
So Mission today offers home health and hospice throughout all of our offices in Southern California. We have 11 different locations for both service lines. We did private duty a number of years ago, and just realized, as many of you over at 24-Hour Home Care probably recognize, to do these businesses, you have to be an expert in order to be successful. And, from the employees that you manage to the types of patients that you get, it really requires a different mindset. And trying to be all things to all people is really difficult because what you find is there's people who are waking up and only thinking about that one post-acute care service, much like, 24-Hour Home Care thinks about private duty, as we think about home health and hospice. So we really found that it was better for us to partner with different companies and allow the experts to really do that type of work, which was, really different than, kind of the skilled care that we, had kind of our primary focus on.
Yeah, it's a great point. We always talk about the jack of all trade, master of none conversation, and how we take the same approach with partnering with organizations that do what they do incredibly well and are the experts at that. So I do remember vividly when we first kind of were starting in San Diego, that Mission was the company that we saw everywhere. Did Mission start in San Diego before it branched out throughout California? Was that the first location?
Yeah, it was. So still headquartered here in San Diego. So this is obviously, our flagship. We started 10 years ago. It's actually an incredible story. The four founders of the company actually bought a Medicare license from the IRS. So it was a defunct home health license that had some patients and some employees. They hadn't paid their payroll taxes, and we picked that up, and literally that has grown into what it is today with 11 offices throughout Southern California and taking care of close to 2,000 patients on a daily basis.
And so what really was the difference for Mission in San Diego from the other competitors that really helped it catch on? And then what were some of the learning lessons that you had as an organization as you started to expand outside of San Diego? Because San Diego, for people that don't know, is a unique healthcare market. It's one of some of the best healthcare in the world is located there, but it's also very community feeling and very tight knit. So I'd love to hear a little bit about kind of the growth in San Diego and then growing outside of it as well.
Yeah, I think, the growth story really was, we're going to do things very differently than some of the places that, folks have worked at prior. And, is we're going to take care of employees first. And we're also going to try to, do the things that a lot of other competitors, wouldn't do, whether it was, take higher acuity patients, take different insurances, go out to, remote areas that other providers wouldn't go to. And that's really how it started. We started by, kind of cutting our teeth on taking the toughest patients and going to cities that even if you lived here, you didn't know existed in the county boundaries. And that obviously creates a lot of challenges, but your community partners start to recognize that you're trying to help. And, little by little, they, want to work with you more. And that's really been the recipe for success, since inception. And I think as we expanded into other markets, we kind of followed suit with that same mentality that if, we kind of grow from the inside out, we'll have some pain points in the beginning, but, ultimately it'll be, the success of the organization. I couldn't agree more with you, Zach. San Diego's pretty isolated, right? You've got, Mexico to the south of it. You've got a lot of empty land to the east of it before you hit, Yuma. And then, there's quite a bit of space before you get into really Riverside and Orange County. So, the healthcare community isn't as, there's not a lot of commuters. People stay in the county. They work in the county. There's not folks kind of coming in from different counties. So it can have, some really positives and some really negatives from that. One, you're either an insider or you're an outsider. And I think probably 24-hour probably experienced that too, coming from Los Angeles. It takes some time to really get people to trust and believe that, you're there and that you're, going to, really adhere to kind of their standards. And, they'll challenge you with tough cases or, unique scenarios. And, if you can accomplish that, usually, the community will let you in. So we had a lot of success with that in San Diego, which we think, kind of toughened our skin because, you obviously have a lot of failures in that process of growing. And then as you get into different communities, I think, for us, being such a culture focused company, one of the biggest challenges was, making sure that culture, was really felt and believed in every location, even though it may not be people coming in under the same roof, for different meetings or, company events. And, I think we've done a good job of making sure that, in a technology age, we stay, just as present with our locations that are far away from us. We obviously go out to Palm Springs, which, is a 3-hour commute, and as far up north as Ventura and Santa Barbara, which, with LA traffic can be, a 5-hour, sometimes a 6-hour, sometimes a 10-hour drive from San Diego, and you can't fly there. So, the ongoing joke that I've always shared is that I can actually fly to Atlanta, Georgia faster than I can drive to Ventura, California. And, it kind of, though you may be a regional provider, it kind of shows you, how you still have to function almost like a national provider would.
Right. Although that was a great transition, because I do want to ask you a little bit about the whole COVID-19 challenge, and you touched a little bit on having to build a culture that works even if you're not in the same room, so that's a great kind of lead into. I'll start just kind of with a generic question. What were the main impacts, just at kind of a high level, of the COVID-19 crisis on your delivery of care?
It's a great question. We could probably spend a couple of hours probably just talking about that question. So I'll try to stay pretty high level. Here in California, we were obviously one of the states that got hit pretty quick, faster than the rest of the country. Obviously you had the state of Washington, and then Northern California, and then very quickly Southern California, I think even before really New York City started to see it. So, we feel like we were, probably ahead of a lot of other providers in other parts of the country because of just the sheer timing. So as we were learning, everybody was learning. So there wasn't really a playbook. There wasn't another company that you kind of mimic, what they did to have successes. I think, the first thing that we recognized was, we really needed to find our way through getting the right, protective equipment for our employees, because we knew that if we didn't have that, it would be very, very difficult to be able to care for the patients that were ultimately going to come to us. So, we really spent, an inordinate amount of time. I'll tell you, my job, looked very, very different pre-COVID than it did during COVID and even now. But I think there for about 45 days, I became a procurement manager of supplies. So that kind of explains to you, how important that was. So, we were very fortunate in being able to, get some things through non-traditional vendors. And I think being a smaller provider, allowed us to be able to do that, where we were getting, masks from painting companies. We were getting, gowns from people who do car resurfacing. We really found, different equipment through different vendors, before kind of the world locked up, which was happening kind of almost minute by minute. In fact, there'd be times where, you'd have things in your inbox, and by the time you went to go check out, the supplies were gone. That's literally how fast, stuff was moving off the shelves. So, for us to be able to do that, I think was, just really changed what our focus was. The second piece was really trying to get an understanding of how to educate our clinicians and how to educate our patients. Obviously when you have a virus like this, we had China to be able to kind of use as an understanding of kind of what they experienced there and what the virus was doing. But so many unknowns really created just a massive amount of anxiety in our field level clinicians as well as in our offices. So, we spent a lot of time really trying to understand what we needed to do as a company. I think, internally what we did is, we try to identify what individuals were, kind of non-essential to the day-to-day business and, made them remote employees. It also gave us the ability to really space out kind of the essential to the day-to-day, folks who needed to be in an office setting. So we felt like we did the right things there. We were probably ahead of almost every county, state, and federal mandate by at least a week or two. So I think we did a good job of being proactive. We had masks on employees long before it ever became a requirement. We actually then, with our clinicians, created COVID teams. And in each market for each business line, what we found was having an isolated group who was going to care for these patients and or care for patients who were in facilities, nursing homes, assisted livings, board and cares that had COVID present, that would be the best way for us to be able to really make sure that we were, one, ensuring they had all of the right equipment Two, that they had the right education. And then the third part is that we needed to make sure we kept the team isolated from COVID, because as we're seeing, non-COVID impacted patients and going into non-COVID impacted facilities, we didn't want to be a carrier per se. And that's how we kind of dealt with it. Today, we're continuing to keep COVID patients on our service. We've admitted an extraordinary number of these patients, which obviously are very, very tough to manage for both home health and hospice. In hospice, these patients are very, very sick, and obviously the respiratory distress, makes these challenging cases to manage because you're managing active symptoms. When you're dealing with home health patients, you're dealing with patients who've been, in many cases, in the hospital for really long periods of time. We've seen some 3 and 4 week patients who've been lying in a hospital bed. So when you think about the rehabilitation of not only the lungs, but the body, right? The physical aspect, the therapy components, patients were coming out extremely weak. But I think, we did a good job. We've had some great success stories, and the team has really responded to, I think, having the equipment that they needed, and us being able to really be a resource for our community partners to take these patients. And some of the stories are just honestly heart-wrenching as to what you hear staff is doing. I'll just give you a quick story that I think, you guys would be interested in. We had a little family that we admitted down in southern San Diego. Hispanic family, is an older couple, didn't have any family, didn't have any friends. The patient actually came on to hospice. It was the wife that came on to service. And when we were actually doing the admission, what we found was that there was no food in the home. And, the husband was afraid of going out because, English, not his first language. Obviously the fear factor, he's afraid of bringing his wife home, who was coming out of the hospital, and she didn't have COVID. But it obviously impacted them and how they were living their life. The neat part is that had they not accessed services, we wouldn't have gotten a social worker in there who was able to get them connected immediately with a food bank to have food delivered into their home so that they didn't have to go out. But the really cool part of the story was the nurse case manager actually went home and actually made a dinner for that family, actually brought it back to them so that they'd have a hot meal. So when you think about, what we do and the impact that we have, right? This wasn't a COVID patient, but somebody who had been impacted by the COVID environment. Had they not accessed these services, God only knows, what would have happened to that patient and that family. And, and the nurses really didn't even talk about this. It was something that was kind of just kept amongst themselves. Nobody was doing it for fame or glory. They did it because it was the right thing. So when you see clinicians doing things like that, when you're sitting in the office trying to procure equipment and working through all of the, the financial challenges that COVID has had on healthcare companies, those are the things that kind of kept you up and kept you working, making sure that you were supporting that group doing that kind of work.
Awesome.
Absolutely. That is incredible. And thank you for sharing. You're right. We do love hearing, those stories, and it really is incredible. I'm going to pass it over to Gavin to talk about things non-COVID related in just a minute, but I just wanted to follow up with just some last questions. We're also dealing with going into the home as well. And one of the things that we found a lot to be a huge challenge that we maybe hadn't expected as much at first was the fear factor and getting people to accept having help in their home during a time of so much fear. We talk constantly that fear is kind of everyone's biggest competitor now. And so I wonder if you guys kind of experience the same thing, and are you guys using any remote, telehealth style services, or trying to reach people in that way also? And then the last part I'll just ask, and then I'll just let you kind of go. You had mentioned some of the financial impact. I'm curious, have there been reimbursement challenges or changes or things that they've done to try to help providers during this time?
Yeah, so I'll take the first question. I think that the fear factor is real. And, when you think about nursing homes, assisted livings, board and cares, obviously having a lot of seniors all in one tight space, they obviously became very concerned, especially as many of them had, active cases. The spread was, was significant for many of those facilities. And so that fear factor really kind of just permeated through, I think, the industry, where if you didn't have COVID in your building, you try to lock your building down and make sure that nobody came in. And if you did have it, you were still trying to make sure that, it didn't get, spread within the four walls of your facility. So we absolutely saw that as a massive issue in delivering care for both home health and hospice. And then on the home visits, we saw patients who were canceling visits. So I think initially what we saw was a lot of folks who were wanting just the critical need visits. So if there was an infusion being done, or if there was wound care, or if there was, medication, key medication administration that needed to be done, it was those kind of visits that, were being kind of allowed in the facilities and that patients were still okay with. But when it came to some of the ancillary services, people were trying to find, alternate ways to not have those folks come into their homes. So, like a home health aide is obviously very, very important in both home health and hospice. And, many of them had been turned away. Therapy visits were being declined because, people's strength and, mobility may not have been, top priority. They were more worried about, obviously, the more interactions they had, the more potential exposure. So, that had a big impact. And it had a huge impact on, the business aspect of home health and on hospice, where, in home health in particular, you're paid by the visit. And when people are canceling visits, obviously, the employee's not working, that you're not getting reimbursed for those missed visits. There's also a LUPA adjustment, and I don't want to get it too deep into it, but basically, if you don't do a certain number of visits on certain types of patients, your reimbursement changes dramatically. So we absolutely were faced with all of those challenges, in addition to having to spend hundreds of thousands of dollars above and beyond, what we would typically buy from a supply standpoint. And I think, every healthcare provider has been impacted by that. When I think about it, as we looked at what we had, the day before we decided that we needed different type of PPE, outside of a handful of gowns, obviously you always have gloves, and you have a handful of goggles. But when you start thinking about, hair bonnets and, massive amounts of gowns, and, we actually have gotten respirators for all of our clinicians, full-fledged respirators, which we felt like was a big step for all of them and feeling safe. We didn't have any of those things. So I think our initial spend was over $100,000 above our normal supply spend for home health and hospice in the first, couple of weeks, just securing equipment. So, when you put all those things together, and you're trying to do the right thing by taking, COVID patients, obviously it puts a massive strain on post-acute care providers who are trying to really be a resource. And, I think what the hospitals were asking us is, they needed us to take these patients as one of the larger providers in Southern California to free up beds. And, we wanted to do our part, but it absolutely was challenging. I will say that the federal government stepped in quickly. I know that obviously there's always acts of Congress that we talk about to get things pushed through. But really the government came through with, a lot of different programs that could help all different types of providers, specifically providers who were taking care of, Medicare eligible seniors. So the CARES Act definitely did some things to help offset, a lot of the losses that we saw in volume, or the expenses that we had related to COVID, the overtime, there's so many places where literally almost every expense, went up due to COVID, due to whatever reason. And you could have a conversation about each one. So I was really pleased at how the country came together, in all honesty. I think it was really neat to see how people were supporting each other. We saw, various healthcare providers, trying to help each other with equipment, trying to refer patients to, agencies that could provide the right support. It really was, people banding together, trying to do the greater good for the patient and obviously fighting the virus. So, we feel very fortunate that we were a part of it and are a part of it. At the same time, feel very thankful that, there was some government aid that could come in so that we could continue to keep doing it. And we really believe that this will be something that carries on for, quite some time. I know as, some of the things are changing in various counties and, some of the stay-at-home orders are starting to loosen. We're actually taking just as many, if not more, COVID patients today as we were 45 days ago. And we believe that, with folks being out and about more and obviously, being around other individuals, that will have some type of impact where, we will see more of these patients being exposed and potentially more of these patients, needing post-acute care services. So, we're here and we're ready to, continue to help in any way that we can. The other thing that the government did that I think was really helpful was, in particular on the home health side, they removed the skilled need. So one of the qualifying factors for seniors is that they have to be, I'm sorry, not the skilled need, the homebound status. So patients have to be homebound in order to receive home health services. And, they removed that so that seniors could access care in their home as opposed to, doctor's offices or outpatient therapy centers. I think the national associations did a really nice job of advocating for finding different ways to care for seniors in their home. Obviously, that will change once, COVID kind of goes away. But it's allowed us to probably take care of more patients who, wouldn't have normally have qualified for services. On the telehealth side, I think there's a couple of things that, telehealth has been kind of getting hot for a while in the post-acute care space and really in the physician practice world. We have been doing more of it, in particular on the hospice side. We do a lot of it on the home health side, but as of today, it isn't a reimbursed visit. So there's still legislation that's being pushed to see if home health will get included in the telehealth reimbursement plan. So when we do those visits, via telephone, whether they're a FaceTime or whether they're just telephonic interactions, those are just done in addition to the care that we're providing in the home. So, we're preparing that, the industry will probably move towards that. But I still think it's a challenge for our industry where, a lot of what we do is touching patients, that can't be replaced with telehealth like a doctor's visit can, right? In a doctor's visit, a lot of their assessment is just a visual assessment, but they're not necessarily providing treatment. When you're providing treatment, it's really tough to provide treatment through the phone. So we'll have to have a blend if that does happen. But I think anything that we can do that helps patients get, more care or care in a delivery fashion that doesn't expose them as much, is something that's probably going to change for all of us, whether you're healthy or whether you're not, as we move forward in the new era.
That is some great info, Paul, especially with the telehealth. I think I might have been one of the ones who was misinformed as well, as I thought you guys were starting to receive actual reimbursement for it. So appreciate that clarification.
Yeah.
I had that misconception of home health. What are some other misconceptions that you see, keeping in mind our audience is mostly healthcare professionals, so not necessarily what are misconceptions of the general public, but what are misconceptions of hospitals and physicians of what you guys can do?
Yeah, I think, one of the things that's changed in home health, I'll start there, has been, 10, 15 years ago, what you could do in the home versus what you're doing in the home today has changed dramatically. And on a regular basis, I think physicians and healthcare professionals are amazed at what we can actually manage in the home environment. So things like, deep wound cares and debridements and infusion, that really wouldn't have been done in the home 10, 15 years ago by a lot of home health providers. And today, those are things that we're doing, with quite regularity. And the skill set of our clinicians is quite different than it was 10, 15 years ago. And that really has been, due to the demand of our referral partners where, I think everybody, through, some of the CMS changes around how long somebody maybe stays in a hospital or in a nursing home or what levels of service they may receive in between, more people are getting shorter lengths of stay in every care setting, which usually means that these patients are going home sicker than they were in the past. And I think that home health has really evolved in taking care of that acuity level that in many cases folks are, not always aware that home health can actually take care of. On the hospice side, hospice knowledge has really just grown tremendously. I think still to this day, one of the misnomers, both from healthcare professionals as well as, the community is, that all services kind of stop. And the reality is that, under hospice, there's probably not a setting of healthcare where you will actually get more care than you probably have in any other environment that you've maybe experienced, from top to bottom. And I think that that's still something that people don't understand, because most hospice care is really provided in the home. So folks don't get a chance to really see it. When you think about what a social worker can do when they're willing to sit with a family and work, for 4 to 6 hours on, what the plans are once their loved one passes, or to work through, massive family dynamics to ensure that, everybody feels at peace as their loved one, moves on. I think those are the things that people don't see and they don't think of. A lot of it's really just dealing with the individual and maybe the pain management or the symptom management, that their disease process may be presenting. But there's so much more on the ancillary side that, hospice can deal with that, folks just don't get a chance to see it. So, it's our job to make sure that we tell the stories so that, folks truly understand, what their patients can actually access.
Thanks, Paul. Yeah, I appreciate that. I think one thing people forget as well with hospice is it's not around the clock care necessarily, right? There's continuous care with symptoms that need to be under control, but it's a lot of care, but it's intermittent. So one thing that I've had to learn over my healthcare profession, I was fortunate. My brother-in-law actually had inpatient hospice care in the San Gabriel Valley, but we know that's very, very rare. Is there anything in any other inpatient facilities besides Citrus Valley in Southern California that you're aware of?
There's a handful of them. One of the challenges is in California, it's really more of a licensing issue. There isn't a hospice license certification, so you kind of have to, license them a little bit uniquely. So there's some hospice houses. There used to be San Diego Hospice down here in San Diego that had a inpatient unit, but they ran that much like a hospital. So, for most of the inpatient in California, it's either provided in a nursing home or it's provided in a hospital setting. And that's really for the patients who are, massively acute and dealing with, things that are just very, very difficult to deal with, in the home environment for the family. And you mentioned, about hospice not being 24 hours a day. And you're right, that absolutely is a misconception. I think the other piece that people don't realize is that, as when you're on hospice and there's an issue at 3:00 in the morning, there's staff who are actually working those hours to go see those patients and deal with whatever, issue may be coming up. But it truly is, a collaboration of providing care for those patients. I mean, I know with 24-hour home care, we've had the opportunity as early as this past week to work on, cases where people needed that 24-hour care around the clock where, home health or hospice was coming in, but they needed really the minute-by-minute care because there wasn't the right caregiver set up. And you've got to really partner with all of your community partners. And it's about really care planning beyond just your own company. It's about care planning with all of the various services, whether it's nutritional services, whether it's private duty services, whether it's, any other kind of thing that the patient or family may need. That's usually when patients have some of the best experiences, is when there's that collaboration and that trust.
Awesome. Yeah, thanks for sharing that, Paul. So as we wrap up the show, I want to talk about the current momentum in hospice and home health from a regulatory and maybe even reimbursement perspective. So there's something out there that I think all of our listeners likely have heard of, but may not really know what that is. And that's PDGM. Mm-hmm. And can you tell us how that has impacted you guys, but also how does it impact patients?
Yeah, it's a great question. And I think, for the last year, most home health companies were preparing for PDGM as being, the single biggest challenge that they were going to be faced with come January 1st. It's interesting because obviously COVID, coming in the middle of March, made almost PDGM go away for all intents and purposes, right? At least the thought process and the plans around it. It really was one of the biggest reimbursement changes for home health since the late 90s. So it's quite significant. It was really kind of changing with the times and the needs. In previous home health reimbursement, it was very difficult to take care of, chronic long-term care patients. And there was a heavy emphasis more on, therapy and therapeutic services. I think with PDGM, there was a big focus around trying to take care of higher acuity, and making sure that there was the right reimbursement attached to taking care of COPD and CHF and, non-healing wound patients who we know are going to, probably really need a lot of healthcare, whether it's home health or other services, and they're, going to continuously be chronic. There wasn't always the way to actually get paid for the care that you would provide to those types of patients. So I think, PDGM did some really good things around that piece. But it really changed the way that, companies were looking at how they were taking care of patients and, what kind of programs you had in place. And, all different types of changes around where patients came from affected reimbursement, whether they come out of hospitals or nursing homes. Those are institutional referrals that are, being weighted a little bit heavier versus kind of a community referral. And I think that that's really the government kind of saying, hey, we know these patients are going to be sicker. We know they're going to need more care. And obviously that's broad brushed. But I think in general, we do tend to see higher acuity levels. So that's really been a significant change in reimbursement. I think a lot of companies have been impacted negatively by PDGM, where their revenues were dropping significantly. I think across the board, almost every home health provider has seen a drop in revenue. There's also been some changes to some of the admitting diagnoses. They've become a little bit tighter. So some patients who may have qualified in the past may not qualify in the PDGM world. So a handful of changes that we've been, kind of addressing for 6 months leading up, and then kind of got away from it. But the good news is today, I think, folks are getting back to those conversations of how to take care of those types of patients. I think the biggest challenge for a home health provider is as you're taking on higher acuity, the skill sets of your clinicians has to change. Not every clinician understands how to take care of some of these acuity levels. In fact, as I talked about before, what a patient looked like 10 years ago versus what it looks like today, vastly different. But it also we have to make sure that, the clinical competencies of the clinicians are there so that, one, the patient gets the right care, and two, that we don't ever put an employee in a situation where, they don't feel comfortable doing something that they may be presented in the home. So PDGM was a big change. I think it was easier probably for the larger companies who had, good EMR systems, who had, kind of resources to really be able to do the deep dive and understanding it, and, how to modify, whatever needed to be modified. And I think, many of them, including us, worked through those challenges. But, still to this day across the country, home health services are predominantly provided by, mom and pop businesses where you have a nurse leader who owns the business, is providing care, running the financials. And, those providers are, going to struggle with trying to deal with those changes and maybe don't have a sophisticated EMR that, can help guide them as to, what's happening with their current patient population and how they may have to, maneuver through it. So, we've actually provided some support to some of those smaller agencies, because we still believe that, home health is going to be something that's going to be even more utilized moving forward. And then on the hospice side, we really haven't seen a lot of regulatory changes, a lot of reimbursement changes. Obviously, knowledge of hospice has continued to grow. Communities have gotten more comfortable with it. People obviously want care in the home. And, we've really seen hospice care really kind of continuing to grow, I think, across the country and in Southern California with our company as well.
Awesome, Paul. Again, some great perspective there. So last question as we wrap up. Besides what you've touched on already, do you see any other changes this decade? So, or I guess, depending on who you ask, people say the decade starts in 2021, but let's just say for the 2020s, do you see any other changes with reimbursement or both hospice and home health?
the moment I would say no, I'd be a fool, right? Because if we study history, it really seems to be, if it's not every year, it's every other year, where there's some type of change that's happening from either a regulatory environment or from a state environment or a local environment. So I think, being nimble and recognizing that nothing's ever going to stay the same is absolutely the mentality to have. You've got to be able to really pivot and change along with the times. Otherwise, you really do become extinct. I remember in the late 90s when, home health changed its reimbursement strategies, and, there was folks who literally did not change their behaviors, and, they became dinosaurs and they became extinct because they weren't able to pivot. And you have a lot of folks who kind of live in that, the old days, right? That was the good old days. And what you realize now, and I think, a lot of, healthcare providers have seen so much change that they're expecting it, and it's easier to digest, and there's not as much resistance, and that's both from administration as well as from field level clinicians. So I think our job is easier in that regard, but you also have to make sure that you're really paying attention to what's happening and what's going on, and making sure that you position your organization so that it can continue to evolve. My personal opinion is, and I think that COVID has pushed this even faster than what I would have thought, normally, is more people are going to receive more care in the home. And that's just a reality of a post-COVID world. We knew that was where all the trends were already telling us, right, for private duty and home health and hospice and really all in-home services, was that more people were accessing more care and more services in the home environment. I think a post-COVID world really kind of amplifies that. I think there's going to be a lot of folks who are going to be fearful of going to outpatient clinics or going even to doctor's offices. Exposure in nursing homes, exposure in hospitals or ERs, where people would have traditionally have gotten care. I think today they're going to try to find ulterior motives, and whether that's through telehealth or whether it's through bringing care providers into their home where they feel a little bit more protected and less exposed. I really see that being probably the single biggest change for anybody who's providing care in the home setting.
Awesome, Paul. Thanks for that perspective. And I think most of us, all the listeners, will probably tend to agree with you. So I just want to thank you again for taking the time to be our guest today, Paul. How can folks learn more about Mission Healthcare?
Probably our website is the best, missionhealthcarehh.com. It gives you a lot of information about what the services are, what our locations are. There's also a lot of just great articles on there. There's also a lot of great folks who are willing to just actually talk. We have a centralized intake team for home health and hospice that's willing to talk to anybody who has questions about what kind of care they may be eligible for. And if it's not us, we obviously have lots of great community partners, people like 24-hour home care who, we refer cases to when, maybe there isn't a skilled need, but there's a need for in-home support. So folks can absolutely reach out to us and connect with us that way. And we'll make sure that if it's not our services, that will help you get connected with whatever you may need.
Awesome. It's been great having you too, Zach. We don't do as many shows together anymore. So thank you for joining.
Yeah, thank you both so much. It was a great show today. I appreciate it. Thanks a lot, Paul.
Thanks, guys. I really appreciate the time.
Thanks, everyone, for tuning in to another episode of Pop Health Podcast. We hope you've enjoyed today's episode, and if you have and want to check out other episodes, visit us at pophealthpodcast.com, iTunes or Apple Music, Spotify, Stitcher, and now YouTube as well. Take care.